Last but not least in this special morning session, I'm delighted to introduce Dr. Angela Lowenstern. So Dr. Lowenstern is an interventional structural heart specialist, and I just want to, applaud her for that. We need more women in cardiology to go into this important field. She's an assistant professor at Vanderbilt University Medical Center. And Dr. Lowenstern is going to be talking to us about another important issue about aortic stenosis in women and the role of TAVR in women in improving outcomes of women with aortic stenosis, assessing the evidence and clinical pearls. So Dr. Lowenstern?
Thank you so much, and thank you for having me. I'm so excited to be here. So as mentioned, I'll be talking about the role of TAVR in improving outcomes in women with aortic stenosis. And as per the prior talks this morning, I'll be talking about some of the differences in women versus men with aortic stenosis and some of the gaps in treatment. So my disclosure. So here are the learning objectives for the talk today. So first, recognize the impacts, differences in symptom presentation and clinical significance of aortic stenosis in women. Outline tailored strategies to screen, diagnose, and risk stratify women with aortic stenosis as a means to identify patient candidates who may benefit from treatment. Summarize the updated guidelines and evidence from recent clinical trials and real-world studies of TAVR versus SAVR in women across the risk continuum, and then develop individualized treatment plans for women with severe aortic stenosis. And so this is a very lofty learning objective, so we're going to try to briefly touch on each of these things. So I always like to frame things in terms of patient care because that's really what it comes down to. So I'll start off the presentation today with a case, and then at the end we'll follow up with it as well. So this is Ms. N. She's a 76-year-old woman who presents for evaluation of aortic stenosis. She's referred to my structural heart clinic. She tells me that she's had progressive shortness of breath for 2 months. It started initially very mild. She wasn't even sure that she was short of breath, but now she notices with even minimal activity around the house, she's short of breath. She has some intermittent chest pain with activity, no lower extremity edema, no lightheadedness, and no syncope. Pertinently, she's had a 4-vessel bypass surgery in the past and has known ischemic cardiomyopathy, so multiple reasons why she may be short of breath. Also with hypertension, dyslipidemia, and diabetes. She previously smoked, although quit over 10 years ago, and is independent at home. She's on multiple antihypertensives, but despite this, in clinic, she is hypertensive. She has an obese BMI, 30.7, and examination shows a 3 out of 6 systolic murmur at the right upper sternal border. Her laboratory evaluation is pretty unremarkable except for an elevated BNP at 580. So she underwent an echocardiogram based on her systolic murmur, and this was already done at the time that I saw her. And what you can see just from a couple of the pictures here is that she does have a reduced ejection fraction, about 35%, and her aortic valve leaflets are calcified. In looking at the aortic valve gradients that were obtained, peak velocity maxed out about 3.2 meters per second, mean gradient in the mid-20s, but valve area less than 1, so 0.8. So there's discordance where the valve area is calculated as severe, but the peak velocity and mean gradient are really in the moderate range. And this is not uncommon. We see this all the time in clinic. And really the question is, what do we do next? And so we'll come back to that at the end, but I wanted to start with kind of a foundation of prevalence, burden, and gaps of aortic stenosis. So we know that aortic stenosis is really a prevalent disease and increases with aging. It's a disease of the aging population. And so on the left here is a bar graph looking at a prevalence study from Iceland where they looked at prevalence from patients less than 70 up to over 80 years old. And what you can see is that this increases significantly with each decade of life, with moderate and severe aortic stenosis in patients above 80 years old. Either between 1 in 15 and 1 in 10 patients are affected by this. And similarly in Norway, an observational study looked at prevalence, and you can see almost exponential growth in the 8th and 9th decade of life of aortic stenosis. But only a part of these patients were offered surgery, and that lower line is the surgical group. Prevalence studies have also examined whether aortic stenosis is similar in terms of prevalence between men and women. And what they have found is that in left-sided valvular heart disease, these really should be the same. And so when we're saying that there's lower numbers of patients or women that are diagnosed compared with men, it really should be similar in terms of number because the prevalence is the same. We also know that aortic stenosis is a very morbid disease if untreated. And so the graph on the left is the original graph by Brunwald, really looking at what happens in patients with aortic stenosis. They have this long latent period with increasing obstruction and myocardial overload until they develop this critical point of having symptoms. And once a patient develops symptoms, really the survival is quite poor, between 2 to 5 years of average survival based on symptoms. And you have to take this a little bit with a grain of salt. This was a little bit of a different patient population than we typically see today. These patients had more rheumatic heart disease, more bicuspid disease, but still it's very profound after a patient develops symptoms. The graph on the right is from the PARTNER trial in patients with prohibitive risk for surgery, looking at standard therapy, so medical management, versus TAVR. And as we all know, TAVR offers significant benefit over medical management, but look at that mortality rate, death from any cause in the standard therapy arm at 2 years. It's really remarkable. So despite the fact that we all know what aortic stenosis is, we know that it's a very morbid disease, there's a high proportion of patients that really are not treated. And so this was a study that I did with Matt Brennan at the DCRI, looking at the rate of AVR treatment within 1 year of diagnosis of symptomatic severe aortic stenosis. So these are patients with an indication for valve replacement. And we looked over time from 2011 to 2016, and what we saw is that treatment rates did increase over that time with introduction of TAVR, but it was really humbling to see that over 60% of patients still were not treated. So there's a huge gap in terms of treatment. And the question would be, so why is that? Why, when we know that aortic valve replacement offers such benefit, why are patients not treated? So thinking about before TAVR, perhaps it was a surgical issue. And so studies have looked at why patients were not offered surgery. And there were several predictors, and we may all think that these are pretty reasonable, but age, comorbidities, neurologic dysfunction, heart failure at admission, and LVEF just less than 50% were all predictors of not being offered surgery, potentially life-saving surgery. And so with the introduction of TAVR from 2010 through 2019, where now patients across the risk continuum are eligible for TAVR from prohibitive surgical risk to low surgical risk, all patients are eligible. One would think and hope that our treatment rates have improved. This was a study that was done by Sami Elmira. He led it looking at patients that were treated at Mass General and Brigham Women's, so two very large academic centers across time, so from 2000 to 2017. And they divided patients into what type of aortic stenosis they had, and they only included patients with a class 1 or a class 2A indication for treatment. And so on the top left graph here, you can see patients who had high gradient normal ejection fraction aortic stenosis, so almost a classic aortic stenosis. And what we can see is that treatment rates did increase over time, but this was accompanied by a parallel increase, and was more in patients that were eligible for treatment. And 30% of these patients still did not have an aortic valve replacement. And this is kind of the best treatment group. In the other groups, particularly patients with reduced ejection fraction in the bottom left and the bottom right, high gradient on the left and low gradient in the right, the treatment rates were even lower. So no aortic valve replacement in 62% of patients with low flow, low gradient aortic stenosis. No aortic valve replacement in 67% of patients with low flow, normal EF aortic stenosis. So really humbling numbers that are really recent and still what we're looking at today. This was also part of their study, and so they looked at, okay, these patients are treated versus not treated. What does this mean for their outcomes? And so the top left corner is the class 1 indication for aortic valve replacement with high gradient normal ejection fraction patients. 30% were not treated. And among the ones that were treated, there was a 58% lower adjusted hazard of mortality. 58%. The bottom two graphs are both the low ejection fraction patients, and these patients overall did more poorly than the patients with a normal ejection fraction. But you can see the really abysmal mortality of patients with a high gradient low ejection fraction who were not treated, with only 28% of patients surviving at about 2 years. And so we have a lot of work to do. We really do. And closing those gaps will be really important. And the first way to do that is looking at screening, appropriately staging patients, and looking at risk stratification. So that's where we'll start here. In terms of identification and evaluation for aortic stenosis, when we think about identification, first things first is go back to the basics, physical exam, listening for that systolic murmur. Once somebody has been found to have a systolic murmur or other concerning symptoms, then the imaging test of choice is an echocardiogram. And with an echocardiogram, you can see multiple things. You can look at the ejection fraction, you can look for other valvular heart disease, you can see the opening of the aortic valve leaflets, calcification, and then, of course, the very important measurements, the gradient, the peak velocity in the valve area. Other steps in evaluation for patients with aortic stenosis, other non-invasive imaging studies, such as perhaps an exercise stress test to look for symptoms, a dobutamine stress echo in somebody with a low ejection fraction, and then a CT scan, both for anatomic planning in case somebody has a TAVR or a SAVR, but also for calcium score that can help determine whether a patient has moderate or severe aortic stenosis when there's discordance on their echo. Invasive hemodynamics with a cardiac catheterization can also be helpful at times. And when somebody has been identified to have aortic stenosis, has had further evaluation, then there's risk stratification and the heart team discussion. So I'll delve just a little bit more into the workup of patients with aortic stenosis now. So as we talked about, echocardiography is really the important first step. And then once that patient has been identified as having aortic stenosis and usually referred to the structural heart disease clinic, almost all of our patients get a TAVR CT scan. And this is really helpful for multiple reasons. This can help with access considerations, whether they have appropriate femoral access for TAVR, calcification on the aorta in case they're a better candidate for SAVR for one reason or another, sizing considerations for the valve, anatomic planning is, are we going to have difficulties with coronary obstruction with implantation of the TAVR? So a lot of really important pieces of information come from that TAVR CT scan. Another part that the CT scan is helpful for is you can actually evaluate the coronary arteries, and if there's no obstruction, then consider using that for coronary clearance prior to TAVR rather than a full heart catheterization. All patients should get an EKG. Patients with a right bundle branch block on baseline EKG are more likely to have complete heart block after TAVR, and so that can be used to help guide discussions. Laboratory assessment, pulmonary function tests, and dental evaluation to make sure there's no ongoing dental infection that could cause endocarditis. And then, of course, different patients have unique clinical considerations that are taken into account. And at the end of the day, then we have a full heart team discussion evaluating all the imaging and testing that has been done and come up with a plan of care. And so now we wanted to dive into just a little bit more about presentation and imaging considerations for women specifically. And so, first of all, presentation. So we talked a lot about in the last presentation, is it the same for women as men? And it's the same thing here. It's not for aortic stenosis either. Women tend to be older, have a lower BMI, higher frailty, lower renal function, more rates or higher rates of anemia, and then more advanced NYHA class symptoms at the time of presentation. And the graph on the right just really exemplifies the age continuum that we see patients at and when they present, and how you can see how it's really shifted to the right for women. Other studies have similarly shown this. This looked at types of symptoms that patients present with, men versus women. And overall, in the graph on the right, this is all patients. Women were more likely to present with symptoms, and when they did have symptoms, more likely to have shortness of breath or dizziness and syncope as they're presenting symptoms. In patients just over 80 years old, women were more likely to present with shortness of breath. And so I hear this a lot of times in my clinic. My female patients will say, oh, I just assumed I was getting tired or a little short of breath because I'm old. And their family members will frequently speak up and say, no, 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 you're much more short of breath than you realize. And so this can be really insidious, and patients don't actually notice symptoms always. And it can, because it's such a progressive disease over time, you really have to press people to figure out if they have symptoms or not sometimes, but it's important to take that into consideration. And then different imaging considerations for men versus women. Similar to previously discussed, women are more likely to present with low flow, low gradient aortic stenosis. And some of this has to do with different ventricular remodeling and more fibrosis in women. Women have more concentric hypertrophy and that stiffer left ventricle. And so then they present with this different phenotype that maybe previously was under-recognized and led to women being treated later in their disease course. Valve calcium scoring is also a very important piece. And valve calcium for a man is not the same as it is for a woman. So by similar aortic stenosis severity, women have a lower calcium density. And so while the cutoff for severe aortic stenosis by calcium score in a man is 2,000, for a woman it's actually 1,300, so much lower. And that just goes to show differences in how the body handles the stress and the changes of the valve. And women have much more fibrous valve changes rather than this calcification. Okay, so now that we've looked at how patients present, how we work them up, what imaging considerations are important, I'd like to move on to different management considerations. And so by the guidelines, there's different stages of aortic stenosis from A, patients that are at risk, up to stage D, which is symptomatic severe aortic stenosis. And the guidelines really recommend monitoring and treatment based on these stages. And so patients with stage B, if they have mild aortic stenosis, really can have an echo every 3 to 5 years, versus moderate aortic stenosis need to increase that frequency every 1 to 2 years. And then once somebody gets to severe aortic stenosis but are asymptomatic, really need to consider close follow-up every 6 to 12 months, and can consider an exercise stress test to see if there's hemodynamic changes that are concerning, or if the patient really does have symptoms that maybe they didn't recognize previously. Once somebody gets to stage C2, which is a reduced ejection fraction, even if they don't have symptoms, or a symptomatic severe aortic stenosis, then they should be evaluated by a valvular heart team and have a comprehensive evaluation. And this is the guideline treatment recommendations. It's a really nice algorithm that you can also look up later, just looking at how we manage our patients with aortic stenosis. And we'll come back to this regards to the patient I presented at the beginning as well. So we know that aortic stenosis is progressive, and timing is really important. You don't want to intervene on a patient too early, although the timing is under increased scrutiny with different trials currently. But you also don't want to intervene too late when there's irreversible damage to the myocardium. And so you really want this Goldilocks sweet spot of optimal timing, just as left ventricular decompensation is starting to develop. And we know that timing delays really can lead to adverse outcomes. The COVID pandemic, for better or worse, allowed us a little bit closer look at this. And so in April of 2020, at the beginning of the pandemic, SCI and ACC issued this joint statement about timing and which patients could potentially be safely deferred for close monitoring for TAVR. And then an analysis after that looked at patients who had expedited treatment versus deferred. And while it did not meet statistical significance, there is that trend towards increased risk of adverse outcomes in patients that had deferred treatment. So when we talk about treatment, what are the treatment options? There's really two mainstays, and surgical aortic valve replacement versus percutaneous. TAVR is the mainstay for decades. It's an open heart surgery, and because of this, there's this higher upfront physical cost on the patient and a longer recovery period. However, for young patients, that maybe a mechanical valve is the better choice. That's the way to do it. And you can also have additional procedures during the same surgery. So if somebody needed a bypass graft, that would be an option. Or if somebody has multiple valvular lesions, then treatment of all of those at the same time is a possibility. TAVR, as we've been talking about, is a transcatheter procedure. And it really has changed the landscape of treatment for patients with aortic stenosis. Patients come in the same day as their treatment. Most of them go home the next day. Some centers are even starting to look at same-day discharge for TAVR. So much shorter recovery time. And you can combine interventions, so coronary interventions, either before as a stage procedure or during the TAVR procedure. There are unique considerations in both for young patients in terms of patients that we, based on their life expectancy, we know would need more than one tissue valve over their lifetime. Which one do we do first? Do we do a SAVR and then do a valve-in-valve TAVR after that? Would they have anatomy that may be feasible for a TAVR and TAVR? These are all things where the field is looking as we go along, and questions that really are still not answered. And so TAVR really, as I said, has changed how we treat patients with aortic stenosis. Previously, patients could only have surgery, and higher risk patients or older patients really did not have treatment. And in the setting of such a morbid disease, a lot of these patients just essentially died of their disease process within the next couple of years. But TAVR has offered now a treatment option for all risk patients. With these treatment options, I now want to dive into a little bit of the considerations for women and the treatment with TAVR versus SAVR. And so this was part of that initial study that we looked at treatment of men versus women, looking at TAVR versus SAVR and across time. And my hypothesis was that with introduction of TAVR, there would be increased treatment over time. And that is what we saw. And both genders had increased treatment over the years of the study from 2011 to 2016. But across time periods, consistently, women were treated less than men. And that's an unfortunate reality. And when women were treated, they were more likely to receive TAVR versus SAVR. And when we looked at overall treatment across different year ranges, race, income, region, and ages, across all aspects, women were less likely to be treated with an aortic valve replacement. Other studies have similarly shown this. This study looked at treatment of women with any AVR across time, follow-up of 60 months, and they noted that women were often diagnosed later, had more symptoms, and again were less likely to receive an AVR, and because of that had excess 5-year mortality even after matching with male patients. Another study showing, unfortunately, the same thing, that overall survival in female patients compared to male patients was much less at 10 years, and they were also less likely to have AVR. And so why is this? Why are female patients not treated as much as male patients? Is it because of the outcomes? So let's talk about the outcomes after treatment. So we know on the far left there are untreated patients, and we know that their mortality is high. So about 30% of patients within 1 year of diagnosis of symptomatic severe aortic stenosis. And that with treatment, this goes down considerably. And men and women had similar outcomes with treatment, with slightly higher in women. And this is related to, as you can see on the right, trend towards higher mortality after SAVR in women. And this had been previously shown as well. Compared to male patients, female patients had higher mortality following SAVR, and this was in the setting of more severe symptoms at the time of presentation, higher frailty, and more severe aortic stenosis by valve area. So female patients were really presenting later, and because of this, potentially, at least in part, were having worse outcomes after SAVR. What about TAVR? So this is from the partner trial. So on the left, graph A is female patients who underwent transfemoral TAVR versus SAVR. And you can see that women with TAVR did much better than they did with SAVR. On the right is the male patients and who had similar results, TAVR versus SAVR. And then we can see this in the STS risk score, where just changing the gender of the patient increases the risk from male to female. In the core valve trial, men and women had similar outcomes for TAVR. In terms of real-world evidence, early TVT registry also looked at outcomes for men versus women who underwent TAVR, male patients in blue and female patients in red. And what you can see is that female patients had higher risk of stroke, but lower risk of death during the time of follow-up. Other notable things from that paper, female patients were more likely to have mitral valve disease, again, were more often deemed frail by the heart team, had increased vascular complications, more frequent non-femoral access, but despite all of those things, despite being treated later potentially, had higher survival at 1 year, which is really interesting. This is a meta-analysis looking at longer-term data after TAVR, and so 30-day outcomes on the left and then late outcomes out to 5 years on the right. At 30 days, female patients were more likely to have major bleeding and major vascular complications, but long-term had lower rates of mortality. And so just to kind of sum up some of these considerations for differential outcomes in women and the unique considerations for women, women are often referred later in their treatment course for aortic valve replacement. And whether this is related to the decreased calcium, being more likely to present with low flow, low gradient, aortic stenosis states, I think it's all multifactorial, but they are generally referred later for treatment. And women reach the same hemodynamic severity of aortic stenosis with less calcification and more fibrosis of the aortic valve. As I said, they're more likely to present with paradoxical low flow, low gradient aortic stenosis, which in itself is a higher risk phenotype. And then considerations for the procedure itself, women generally have smaller body size, can make different parts of the procedure more complex, different considerations for which type of valve to implant in terms of TAVR. And so in this scenario where undertreatment and disparities really still persist, how do we make this better? So I also don't want to leave it on a really gloomy note. So this is an editorial that I worked on with Brian Lindman, who's also at Vanderbilt, looking at what the current state is of treatment for aortic stenosis and what our desired state is. And so currently, quality is really measured by a procedural outcome. So we look at TVT and we look at all the different metrics of centers, but it's really based on patients that underwent a procedure. What we're not seeing is all the patients that have an indication for treatment but that are not treated. And so that's really the blind spot in the current system and what we really need to improve upon. If you think about other areas of cardiology, say STEMI. So somebody comes in with a STEMI, primary PCI is what's recommended. If I told you that 50% of patients weren't getting primary PCI, it'd be a big problem. But that's really where we're at with aortic stenosis. And so what we proposed as kind of the desired state is that quality would be measured not just by a procedural outcome, but also process metrics looking at what proportion of patients that are eligible for treatment undergo timely aortic valve replacement. And there's a number of different ways to do this, starting with changing language in how echo reports are worded, automatic referrals to a heart team, really an opt-out option for maybe patients who have metastatic cancer, palliative care, a life expectancy less than 1 year, so maybe not appropriate for aortic valve replacement, but trying to get all patients seen by that heart team because there really is a gap there in terms of getting patients treated. And so the goal would be that all patients that are eligible get timely treatment with aortic valve replacement. Part of the way that this is happening is in a partnership with American Heart Association and Edwards Life Sciences called Target Aortic Stenosis. And this is a multi-part, multi-center initiative looking at how we can improve the care of patients with aortic stenosis, what are the different hurdles and barriers to treatment, and how we can change those. And so some key takeaway points that I'd like you to consider and take with you is that symptoms are often insidious, and be careful when a patient tells you they're just tired or a little bit short of breath or they're just getting old. I can't tell you how many times I hear that from my patients. So just have a high index of suspicion. If you hear an echo or a murmur on exam, get an echocardiogram and review it for valvular heart disease because it really is common. If there's discordant results on that echocardiogram, so the aortic valve area is severe, but the other measurements are moderate, really that patient should be referred to a valvular heart clinic for further evaluation. And then follow up on your patient's valvular heart disease. Really be a champion for them. Don't let them be one of the ones that falls through the cracks and doesn't get treated. So now coming back to our patient. So looking back at these 2020 valve guidelines that I had up previously. So our patient does have symptoms related to aortic stenosis. If you'll remember, she had a low gradient, but a valve area less than 1. And her EF is less than 50%. So she fits this classic low flow, low gradient aortic stenosis. And the next test of choice would be a dobutamine stress echocardiogram. And so she had this done. This was with 5 micrograms of dobutamine, where peak velocity was in the mid-2 range. But then up to 20 micrograms of dobutamine, she did hit that 4 meter per second gradient, showing that this really is true low flow, low gradient severe aortic stenosis. She had her TAVR CT scan done, which showed appropriate anatomy for treatment with TAVR. These are all the different things that we look at. She had appropriate femoral access to be able to do a transfemoral TAVR, and she had an evolute valve placed via TAVR. And with that, I'll wrap up. Thank you so much.
Thank you. So we have some time for Q&A, so please come up to the microphone and ask us, Dr. Lowenstern, some questions. So I want to get back to, I think, what was really an important point you made about, this asymptomatic aortic stenosis, that this is such an insidious disease, that people start adapting their lifestyle and start doing less and less and less, and then you ask them and they say they don't have any symptoms, but they're really not doing that much. What is your, you talked about, dobutamine stress testing for this low flow state, but what about exercise stress testing for someone who, their echo suggests severe AS, but they're saying, no, I really don't have any symptoms. What is your next approach?
Yeah, so first of all, I question them in multiple different ways in clinic, and so really try to get at any potential symptoms. And so ask them, what do they do now? What is the hardest thing they do now? How about 6 months ago? How about a year ago? Is there anything that they could do then that they can't do now? And a lot of times family members will actually notice more than the patients, and so it's so helpful when their family members come with them to clinic and they'll almost tattle on the patient, saying that they actually really do have symptoms that other people have noticed and they have not. And if I can't elicit any symptoms with a really thorough questioning of the patient and family during clinic, then I do a stress test, just a treadmill stress test, looking for symptoms, looking for hypotension with exercise, or concerning EKG changes.
Okay, great. Dr. Rodriguez.
Thank you for that wonderful presentation. I was just wondering if you're familiar with any community-based screenings or maybe opportunistic screening for aortic stenosis. So in the prevention world, we do a lot of screening for incidental calcium, for example, with non-gated chest CTs, and with the same can be done, I think, for aortic stenosis.
Yeah, I'm not familiar with any kind of standardized screening protocols, but I think that one thing that is starting to come into practice is for patients that do have an echocardiogram, not ordering an echocardiogram just for the purpose of screening, but any patient that has an echocardiogram that suggests aortic stenosis, there are programs now that automatically refer those patients to the structural heart team, so that it's not somebody looking at the echo making a decision whether they should be referred. It's just an automatic referral, and so in that way, kind of taking out one step in the process.
Great.
Hi, I'm Mike Wilkinson. I'm at UC San Diego, and I wanted to thank you for that great talk. It was really useful, very comprehensive. And I had 2 questions for you. One, you did allude a little bit to some ongoing studies that are looking at whether earlier intervention in earlier stages of aortic stenosis might be helpful to patients. I was wondering if you could comment on where things stand with those and your take on whether we are going to start moving in that direction.
Yeah, thanks. That's a great question. So I think that we will be moving towards that. So the current trial that's enrolling, looking at patients with moderate aortic stenosis who have symptoms or high-risk features that can be attributed to their valve disease, is progress, and it's still in active enrollment. And just looking at randomizing patients to treatment with TAVR now versus ongoing clinical monitoring until crossover to severe, and looking at those outcomes. And I think that's where our field is headed. I think we've waited maybe too long for too many patients. But you also have to balance that a little bit with patient age. Moderate aortic stenosis patients are in general going to probably be a little bit younger on the age spectrum and needing maybe potential future valve interventions as well. And so that gets a little bit more complicated with valve procedures. But I do think that we're moving towards earlier is better.
Thank you. And for the pathophysiology, the pathobiology in aortic stenosis, it's something that we're still trying to figure out, right? Why do these patients develop aortic stenosis in the first place? And are there things that put certain patients at increased risk to develop aortic stenosis maybe earlier in life? And I think lipoprotein(a) is one of those drivers of aortic stenosis that has been identified, and particularly the oxidized phospholipids that are carried by lipoprotein(a). But what are your thoughts on that? I mean, where are we in understanding the contribution of LPA or other risk factors to developing aortic stenosis, and how do we use those to identify patients earlier?
I think it's currently a huge unmet need in terms of research. I think it's a great thing to focus on moving forward, is really identifying these patients that are at risk, that stage A, earlier. And so we've done that already with patients with bicuspid disease, right, in terms of family member screening and evaluating those patients. But you're exactly right. The pathophysiology of who develops aortic stenosis and who are those patients most at risk is really somewhere where data is really lacking. I think we're just skimming the surface of it.
Yeah, regarding pathophysiology, I'm just curious. A lot of the women we're talking about are older. They may be already on calcium supplementation for osteoporosis. Is there any data or studies looking at the link between calcium supplementation and either AS or calcification in any parts of the coronary tree, stuff like that?
No data, to my knowledge, of calcium supplementation contributing to progression of aortic stenosis, as far as I know.
But your data shows there's less calcium, right?
Yeah, that's right.
So is it because we're putting the calcium where they're supposed to be and not in where they're not supposed to go?
Oh, so in terms of bone mineralization, is
exactly.
calcium going to bone mineralization rather than the aortic valve? Maybe. I'm not sure, but it certainly is different, men versus women. You're exactly right. But the different inflammatory response with fibrosis versus calcification, men versus women, I think there's a lot more data to be discovered in terms of exactly why women's bodies respond differently.
Thank you.
Hi, my name is Josie. I work at UCSD Cath Lab Recovery. My question is, where you practice in Vanderbilt, does your program have same-day discharge or next-day discharge?
So ours is next-day discharge. So patients come in same day for their procedure and then next-day discharge after TAVR. And there has been some brief discussion of same-day discharge, but not yet, no.
Yeah, where you practice, do you see a lot of complications post TAVR?
It depends on the patient and unique factors, but I would say lower than average complications. And so the vast majority of our patients go home the next day. Thank you.
So I wanted to ask you, we've talked about the low flow, low gradient aortic stenosis, and your case example had a low ejection fraction, and you do the dobutamine test. But frequently we see these patients, particularly female patients, that have small LV cavity size, and they actually have hyperdynamic EF, so their EF is like 70, 75, but their stroke volume is actually low if you calculate their stroke volume because their cavity size is so small. and they have, there's some question about their severity of the aortic stenosis in those cases. I don't know if any comment, it seems silly to kind of do dobutamine when their EF is already really high, but their, stroke volume is low, and so you wonder whether they have an inappropriately low gradient and that really their AS is more severe than their peak gradient.
Yeah, I think those are some of the most challenging cases in trying to sort that out. I think the calcium score can be really helpful in trying to determine that. And so if somebody has a low stroke volume, normal EF, but a high calcium score, we tend to treat those patients with AVR. If their calcium score is very low, BNP is normal, there aren't a lot of other things suggesting that maybe their shortness of breath is related to their valvular heart disease, then we tend to just closely monitor those patients. But I think they are some of the most challenging. You also can consider invasive hemodynamics to get just another data point. But I agree, dobutamine doesn't make a lot of sense in those patients, and I haven't found it to be that helpful.
Question?
And just underutilization of CABG or other interventions in women. And part of that may be driven by that higher STS risk score that we do see. And I wonder if we've homogenized women in that score, and wondering, should we just have man-specific, woman-specific risk scoring with different variables that might go in with different weights?
I mean, I think that's a great idea. I think that, even classification of aortic stenosis and the gradients and the peak velocity that we use for aortic stenosis really were built mostly on data from men. And so making it much more women-specific, both for aortic stenosis, but also the STS risk score, and looking to see if that data needs to be updated, I think is an excellent idea.
Thank you, Angela, for such an amazing talk. I have a question about valve-in-valve, and it really gets to the durability of TAVR. And so I'm seeing, at least at UC San Diego, we're starting to do a lot of valve-in-valve procedures, which is nice because they're still avoiding surgery. Can you talk about some of the data on valve durability, and also if there's any data on how valve-in-valve procedures perform over time?
So valve durability, I think we're getting more and more data, obviously, as time goes on after TAVR. And the best data, I think, would argue that the TAVR valves, tissue valves, have similar durability to surgical tissue valves. In younger patients with end-stage renal disease, diabetes, there may be less durability, increasing failure rates earlier rather than later, and those are similar patients that have that issue after undergoing SAVR. In terms of valve-in-valve, I think that there is a paucity of data, and I think some of that depends on patient age, what caused the initial valve to fail to begin with. Was it just, it's a 10 or 15-year-old valve, or were there other considerations?
I have a follow-up question. It's really interesting to me, also in terms of durability of both surgical and TAVR valves, the more cardiometabolically optimized a patient is, so they do better.
Yep.
I mean, I've seen people who have had either SAVRs for 25, 30 years, or even TAVRs now for 15 years, and when I look at those patients, it's the patients whose diabetes are very well controlled, their lipids are perfect, their blood pressure is great, their BMI is within range. And I'm just wondering, I mean, I feel like that message isn't getting across, which is cardiometabolic optimize these patients, and these valves will survive forever, or at least for a long time.
Yeah.
Why, in the interventional cardiology community, why is nobody talking about it, and are there any studies?
Are there any studies? I'd have to look. None that come to my head just right off the bat. But you're right, it's something we do need to talk about more. And we discuss that as a heart team, kind of not in, as our own private meetings. Do we think that this patient who's 65 with terrible end-stage renal disease, uncontrolled diabetes, how long is a valve going to last them? What would a next valve look like? What is their life expectancy? But it really is something that should have broader discussion, because we do prevention, aggressive secondary prevention for patients with coronary artery disease, for patients with PAD. Why aren't we doing those kind of simple things to reduce inflammation, reduce wear and tear on that valve for patients with valvular heart disease? a great point.
Where are we with doing TAVRs in younger patients? So not necessarily not a bicuspid, but so younger patients, they have a lot of years ahead of them. So traditionally they go to surgery for something more durable. But now we've been talking about valve-in-valve, and it seems that younger people, even those that are low risk, younger people, are we shifting to maybe considering TAVRs in those that if they do outlive their valve, that they maybe could then just have a valve-in-valve, as opposed to trying to spare even younger adults who may be good surgical candidates, but people don't often want an open heart operation.
Yep. That's a really tricky one, and so it depends a lot on the patient anatomy. So a valve-in-valve with a SAVR then TAVR is always going to be easier than a valve-in-valve TAVR in TAVR, just because when you put a TAVR inside another TAVR valve, you're essentially creating a covered stent. And so you have to have really unique anatomy to be able to do that safely, where you're not going to include the coronaries and cause a big problem. But TAVR in SAVR is much more like doing a native TAVR, and so much more likely to have an anatomy that's feasible to do that. Even with a CT scan pre-TAVR, I would never be able to guarantee a patient that we would be able to do a TAVR again later. And so that's a discussion with the patient, with the family, considering all their comorbidities, what their life expectancy is in terms of which one to do first. And so there's even some discussion in the community about patients that may need 3 procedures. So do you do TAVR, then SAVR, then TAVR in SAVR? And so it's an ongoing discussion.
No, I appreciate it. I've had it come up with a couple younger patients who wanted a TAVR, but they were reasonable surgical risks, so I was wondering what the field was moving on that. Was there any other last questions from the audience? If not, we'll thank Dr. Lowenstern for a fantastic presentation.
Thank you.